today. Thank you for joining us. These slides will be made available on our website as well as a video on our YouTube, and we'll also email to everyone that's registered. Thank you again for joining us for our very last community enrichment of the year. Very exciting. We had 12 really impactful sessions, so I'm really excited. Thank you everyone for joining again. And you guys are ready to go. You just let me know when you need me to slide through.
Sure. Hi, everyone. I'm Sarah. Thank you for having us, first and foremost. I guess we'll start just with brief introductions of ourselves. Like I said, I'm Sarah. I'm a social worker with Gilchrist. My role, I work directly with individuals on hospice, specifically in residential settings, such as nursing homes, assisted livings, and retirement communities, and sometimes group homes. And Rachel, let you introduce yourself.
Hi, my name is Rachel Weitzner. I am the Associate Director of Social Services, so I have clinical oversight over our social workers. And as Sarah said, we're just really happy to be here today. I would also invite you if you're able to, turn your camera on. We like to be interactive. And so it's always nice to see faces. I understand some not always possible, but we're just thrilled to be here today.
Yes, like Rachel said, we're really glad to be here, especially with a group like yourselves who do such wonderful work, especially with intellectual and developmental disabilities, which is sort of where we're going to talk about hospice and the intersection of hospice and this population. So I guess just to start, I want to be up front. Hospice can be a very loaded word to many people. People hear it and immediately think of giving up, or I have a very short timeline, or just it brings up a lot of emotion and it can be scary. So our goal today is not to overwhelm you with information, but I really ultimately to slow things down and talk through what hospice actually is, what it isn't, and how it can support people with IDD in a way that feels aligned with your values. So I'm hoping this can be a conversation and it hopefully doesn't feel too much like a lecture. Next slide, please. So just to give a brief overview of our mission at Gilchrist, our work is really centered on supporting people who are living with serious illness so they can live as fully and as comfortably as possible. That means we're not looking at diagnoses or prognoses. We're thinking about the person as a whole, their routines, their relationships, their communication style, what brings them comfort, what causes distress. And for many people with IDD, those things are especially important because changes in routine or environment can be really destabilizing. So we're committed to access for people. We care for people regardless of their ability to pay. Rachel will talk a little bit more in a few slides ahead about sort of payment and what that looks like for hospice. We work with families, guardians, and, a whole person's care team. And I'm thinking a lot of this might mirror, some services that you provide, and also include things like dignity, self-determination, honoring someone's life and preferences, not just their medical condition. Next slide. I think one thing that's really important to understand about Gilchrist is that we do more than just hospice. We provide care across a continuum wherever you are, at home, or in a residential setting. We do home care, palliative care, geriatric care, hospice with adults, pediatrics. Means that we're often involved earlier than people expect, and in different ways depending on someone's needs. And this is especially important for individuals with intellectual and developmental disabilities because care is rarely linear for them. Someone might be relatively stable for a long time and then decline and then stabilize again. And our goal is to really meet people where they are and adjust as their needs change. So we adjust with them, not, vice versa. And as you can see on the slide, we have many programs geared towards supporting specialized populations like veterans, Jewish support, pediatrics, pet therapy, that's a big one, music therapy, just to name a few. You can see there's quite a bit there. We're also actively thinking about, how we can strengthen the way we support individuals with intellectual and developmental disabilities. It's not, in what I found is that it's really not mainstream, I guess is the term yet, that hospice uh, supports specifically individuals with IDD. So, we've recognized that oftentimes traditional models don't always fit well, and we're trying to be thoughtful in our partnerships and adapting care to these individuals. Um, Next slide. Um, Yes, our geographic coverage. So this slide gives you a sense of where we provide care. And I do want to mention that this map isn't fully up to date. We've recently merged with Inova, and that means that now we also cover the Northern Virginia area as well. But Rachel, feel free to add if I'm missing anything about Inova and that new catchment area.
No, we will be expanding into Northern Virginia in the beginning of 2026. And there is another map that shows that, but really that's just the crux of it. It's through a partnership with Inova Healthcare Systems, and we are really excited.
Yes. Yeah. And so, within this catchment area, this is where we're providing our care. And again, it includes coordinating really with people wherever they are, home, facilities, group homes, doesn't matter. We meet them there. Um, Next slide. What does hospice really mean? This is a big one. I think, like I said in the beginning, when we first started, when people hear the word hospice, the big H word, there's often a lot of fear, misunderstanding attached to it. But really, it's a model for quality, compassionate care for people facing a life-limiting illness or injury. And that's really what it is at its core. So instead of focusing on curing the illness, the focus shifts to comfort. And that might look like managing pain, anxiety, breathing issues, agitation, and just overall quality of life. Um, and we recognize that, for individuals with IDD, this can look different. Someone may not be able to verbally describe their pain. They may show distress through behavior changes, withdrawal, agitation. And so part of what we are actively learning and adapting to is, we're talking with our nurses and our teams on what these nonverbal cues might look like and collaborate with group homes, family, staff, people who know them best, since this is a collaborative effort. We're really at the core, we're really walking with people through this hospice journey. This is a vulnerable time, and we're really here to support not just the medical needs, but the whole person system, and that includes family, staff, caregivers, guardians, what have you. Um, Next slide. So I sort of touched on this already. Hospice is provided It's not a specific building or a specific place. It's a service, and we bring that service to wherever that individual is. I know I've said this a few times already. Private homes. We come into people's homes. Nursing facilities, assisted living facilities, group homes. We do have inpatient units, and those exist for symptom management when symptoms become too difficult to manage where someone lives. But we really try our best to keep someone in their home environment where it's most familiar and most comforting. And especially, again, like with this population with IDD, staying in a familiar place with their caregivers, with their family, with their peers, it can be incredibly grounding, and it can reduce fear, confusion, especially near end of life. And our goal is not to move someone if we don't have to. Um, Next slide. Our goals. The goals of hospice are pretty straightforward. Consistent care with one's beliefs, relieve suffering, improve quality of life. To know that hospice neither hastens or prolongs the dying process, and to walk with people and helping them to achieve life closure. And this is true for the individual themselves that are on hospice, but also for family and support as well, helping them as best we can to feel some closure. We want our care to align with a person's values. We want to relieve suffering, improve quality of life, like I said. And like I said, we don't speed things up. We don't slow things down. We are just with them through this journey and managing these changes as they come. Next slide. Our interdisciplinary team, there's many people that we work with at Gilcrest. It's a very much a team-based model of care. There's the nurses, physicians, social workers, chaplains, volunteers, music therapists, bereavement team. That's a huge one. Bereavement for after someone's passed. We don't replace existing supports. We build with them. And I think if I can emphasize anything enough, our goal is to be collaborative. We are an additional layer to any care that someone is already receiving. So if someone's in a group home, we will try to coordinate with house staff, house managers, any nursing or like contract medical groups that come in. It's really important for us to maintain contact and be collaborative with them. So, collaborating with care managers, service coordinators, um, residential staff, like I said, any behavioral health providers. Like I said, we really want to coordinate with them all. You all know this person, the individual, far better than we do. So we look to the experts of this individual on what behaviors they're displaying, if there's any changes. It's collaborative, and we really try to utilize their individual's care team to help inform us on how best to guide their care. Next slide. Okay. I think I'm gonna turn it to Rachel now to
So
continue on.
one of the things that comes up a lot is these terms, hospice care, palliative care. Sometimes they're used interchangeably. I think there's a lot of confusion in terms of what they mean. So I want to just talk for a minute about what palliative means versus curative care versus hospice care. So when you are diagnosed with a serious illness, there are a whole group of specialists whose job is to try and cure you. They provide curative care. If we're using cancer for an example, they're the people who provide you, chemotherapy, radiation. It's all geared towards trying to cure your disease. There may also be a group of people whose sole function it is to try to make you feel as good as possible, to try to help alleviate the symptoms of the disease or sometimes the symptoms of treatment. That is palliative care. Palliative care does not necessarily mean that someone is on hospice. It just means that the focus of that care is not on curing their disease. So hopefully, anytime someone is diagnosed with a serious illness, they are both receiving curative and palliative care. As a disease progresses, as we look at the disease trajectory, people might start to receive less curative care and more palliative care. And certainly there's a point at which the doctors may say, we don't have any more treatment to cure your disease. But what still exists and what exists until the very, very end of someone's life is treatment designed to make someone feel as good as possible, to treat the symptoms of that disease. And so that's where we come in. When the prognosis is less than 6 months to live, hospice can come in and we can start providing palliative care. And all that really means is the focus of our care. We are not going to cure anyone, but we are going to work very, very, very hard to make you feel as good as possible. Sometimes we hear people say, oh, what, hospice? I'm just giving up. I promise you, we are the opposite of giving up. We work very, very hard every day to make someone feel as good as possible. We set treatment goals, we provide anticipatory guidance on what to expect, and we work with a team of specialists that are really going to aggressively manage people's symptoms. And we will do that until the very end. We will never say there is nothing more we can do to help control your symptoms. We will continue to try. And so that's what palliative care is. It is care that is not looking to cure you, but is simply looking to make you feel as good as possible. And we can go to the next slide. I think there's a cute little chart there. So again, this just compares hospice versus palliative care. Palliative care can be at any age, at any time of a disease, versus hospice care, we're really talking about less than 6 months to live. Palliative care can and should coincide with curative care. And it's a big difference. We're going to talk about how we're paid, but there's a different structure in terms of how palliative and hospice care is paid for. I want to pause for a minute. I know this is a place that it gets a little tricky, and see if anyone has any specific questions about hospice or palliative care, or honestly, anything that we've said up till now.
We
Okay.
usually wait until after the presentation, just because this is recorded and to make people feel a little more safe. Then we turn off the recording and ask questions. There is one question in the chat, but since you're asking questions,
Yeah.
Are life enrichment programs available to anyone, or only those in one of your care programs?
It's a great question. Unfortunately, our life enrichment programs are for our patients in one of our programs. But I would say if you are looking for a specific need, and there's one exception, which I'll talk about in a moment. If you have a specific need, if, for example, if you're looking for pet love referrals or other referrals, please feel free to reach out to Sarah or I. We're happy to try and connect you. The exception is our grief care. Our grief care is open to anyone who has experienced a loss. You do not have to be enrolled in one of our programs or have lost someone enrolled in one of our programs to take advantage of our short-term bereavement counseling or our bereavement groups. And at the very end of this presentation, there is a phone number. If you call and you ask for information about our grief services, they will connect you.
That's awesome. Thank you so much.
Absolutely. Okay, do you think we can go to the next slide? So who's eligible for hospice? So under Medicare guidelines, you have to have a prognosis of less than 6 months to live, and you have to have 2 physicians who certify this. Medicaid and most private insurances have the same eligibility requirements. That is not to say that if you live more than 6 months, that we will kick you off of hospice. We have plenty of patients, as I'm sure Sarah can attest to, who are on our service more than 6 months. We recognize that they're Dutch doctors. They can't tell the future. Don't tell them I said that. But it is that they have an expected prognosis of 6 months or less. Next slide. So how is hospice paid for? So this is the question that everyone asks. I assure you that everyone is eligible for our services. So there's a few different ways hospice can be paid for. If you have Medicare, it's covered benefit under Medicare Part A. I should say that hospice is reimbursed at 100% for Medicare, not at 80%. So those of us who are used to the 80-20 for Medicare, hospice is reimbursed at 100%, which is kind of amazing. We have to get to the end of life to finally get reimbursed at 100%, but that's a different presentation. Managed Medicare, also 100% with Medicaid. Commercial insurance is slightly different. It is always covered. It's almost always covered at 100%. Sometimes there are co-pays. And if people can't afford their co-pays, then we can work with them through our charitable care, which is the last way. We do have patients come on service who do not have any insurance. And we do have a large charitable care fund, and we are able to take care of that. Same thing if we have people who come on with commercial insurances and we need to tap into charitable care to pay for their co-pays. Jenny Gilchrist Vance, who gave the initial funds to start Gilchrist, it was very specific. Part of her mandate that we never turn anyone away for lack of an ability to pay. So I break this all down because people have questions, but at the end of the day, no matter what insurance people have, we will make sure that they can take advantage of our services. Once you are on with Gilchrist, there are no extras. So it's not this isn't it's a buffet once you get on there, not a la carte. So you don't pay extra for music therapy. You don't pay extra for pet love. You don't pay extra for things. Once you're on hospice, you get the whole shebang. And it's a lot of us. Next slide, Heidi. I think you can go to the next one. Thank you. I'll punt it back to Sarah.
So thanks, Rachel. So services and benefits provided through hospice care, there's a lot. We cover a wide range of services. Medications related to the terminal illness is covered. Medical equipment and supplies, nursing visits, aid supports, spiritual care, respite for caregivers, inpatient stays if needed, like I mentioned earlier, bereavement support. Really is a lot of services and supports that we offer. And like Rachel said, none of it is an extra cost. It is all included. When someone is signed on with Gilchrist, these are the things that they receive, plus more. I can also say that people can also defer, not nursing, but I would be sad, but sometimes people feel that they don't, need or want a social worker, and that's okay. We respect that, and maybe I'll check in a month or 2 months' time just to check in. But, you also don't have to utilize every single thing that we offer, though, of course, it is greatly encouraged. Next slide. Can I change my mind? Yes. And someone can revoke hospice at any time, at any point of care. It must be done in writing. That would usually be with me, someone like me, a social worker. And the individual would sign, or their responsible decision maker would sign revoking hospice. And once it's signed, it's effective that day. And people oftentimes revoke because the family or the individual decides that they want to seek curative treatment. is one of the main reasons for people revoking. It happens, and there's no wait period to come back on either. So if you revoke and then you seek curative treatment, and whenever you're ready to come back, you can come back. Next slide, please. Why are early referrals important? One of the most common phrases I hear, and I know most people at Gilchrist hear, is "I wish we knew about you sooner," or "I wish we had started this sooner." Earlier referrals gives us time to build trust, to understand communication style, learn routines, manage symptoms before they become a crisis. Really wanting to build a relationship, and the main team that is assigned when someone's admitted is the routine care team throughout. So it doesn't usually change unless something's going on off hours and you need an on-call visit. Usually that's from one of our on-call nurses or social workers. But the routine care team remains the same. And so people develop trust and a relationship with us. And I think sometimes you can feel kind of this relief come off of them, and people really wish that they had started that sooner, because it really is such a benefit to individuals and their families. Next slide. When do you call us? When someone's having a rapid health decline, when you're noticing increased hospitalizations or trips to the ER, signs of increasing illness, wanting to focus more on quality of life over aggressive treatment, when someone has difficulty completing daily activities in regards to disease progression, if you call hospice, we can come out and do an assessment, or just have someone come out and talk with you or the family, the individual, what have you. Calling hospice doesn't mean you're automatically enrolled that day. It can be a process, and making sure that the family and the individual is comfortable and understanding. And so we do that a lot, having someone come out and provide education and sort of walk through more in depth what hospice is. And so individuals can make an informed choice on whether they want hospice or not. And hopefully, after hearing those explanations, kind of like what we're reviewing now, people feel more comfortable and kind of demystified hospice a little bit. And hopefully it won't sound so scary. Next slide. Okay, so we'll talk about, we've touched on a lot of these, I think, already throughout this presentation, but we'll go over some myths versus reality. We talked about this earlier. Hospice is a place, and hopefully you've learned now that hospice can really be provided at any place that you call home. Hospice care is just for the elderly. No, hospice care is provided to people of all ages. We have a pediatric program with Gilchrist, so hospice is provided from infancy through adulthood into geriatrics, the whole life cycle. Choosing hospice means I only have days or hours to live. This is a big one that I hear often, and this is not true. Hospice care is for people who have decided to focus on their comfort and quality of life. And like Rachel said, you need a prognosis of 6 months or less. That doesn't mean that is the reality, but that's what the doctors need to sign off on. Like I said, oftentimes people come on and there's like an immediate sense of relief knowing that their symptoms are controlled and that they have an additional layer of care, of eyes on, and support, and education around what's happening to their bodies or to their loved one's body and what they're going through. Medicare requires a patient to be a DNR, do not resuscitate. This is not true. We do have patients who choose to remain a full code and to receive CPR. So hospice definitely can be provided, even when someone wishes to be resuscitated. The only caveat to this, and Rachel, correct me if I'm wrong, but if someone needs to go to our inpatient unit, we do not accept patients who are full codes in the
We do it. So
inpatient, or we do
we
not.
we do. So we
Oh,
can
we do. Okay.
if you go to one of our units, you can still be a full code in one of our units. It's just that our units are not equipped to do resuscitations. So
Okay.
similarly, we will call 911 for a patient who is there. We're a hospice unit. We don't have those types of emergency equipment necessary. If it's our Towson unit, we are located feet from the hospital, so they respond. EMS responds very quickly. But yes, we do accept patients into our unit who are full code.
Okay, next slide. Yes, so hospice care myth is hospice care managers. Hospice care manages pain by only using addictive narcotics. And this, that is just one tool that nurses may use or recommend, but hospice utilizes many methods to manage pain and other symptoms. And a lot of times, social work can address more of the emotional pain. And I think sometimes when those are managed and talked through, there can be a lot of psychosomatic symptoms that individuals experience, and amongst other methods and tools and chaplain for spiritual care. Myth, hospice will starve me and stop all my medications. No, people can eat and drink whatever they want if they're able to safely. Medications are reviewed with the patient and or family or caregiver decision maker on an ongoing basis. So this is something that is constantly reviewed to ensure that they are in line with comfort and improving someone's quality of life. And I think that this is another really big misconception. That hospice comes in and we say, no food, or you can't eat that, or, or take everyone off their medications. I recently had someone who had been told by her physician that she couldn't, have a glass of wine, and that's really all she's wanted. And so, in working with our care team, we were able to find a way to ensure she can safely have even just a small bit of wine with her dinners. Is something that she had been doing for decades, and something that she really missed with as part of her nightly ritual with her husband. And so we worked together to make that happen for her. And last myth, only individuals with money have access to hospice care. And Rachel touched on this when she talked about payment and what that looks like, who pays for hospice. And hospice is provided regardless of one's ability to pay. Most commercial insurances, Medicare, Medicaid, pay for hospice 100%. And if an individual is uninsured or underinsured, as Rachel said earlier, Gilchrist will work with that individual to ensure services are provided. That, as Rachel said before, that's ingrained in our mission and the founding of this company. Next slide. Continuum of care. So this slide really shows how Gilchrist supports people across all different stages of serious illness. Having services across the continuum of care helps with smoother transitions, better coordination, which is especially important for individuals who have really complex care needs or care networks. Next slide. We do offer at Gilchrist specialized geriatric services. So our geriatric care program supports older adults with serious illness well before hospice is needed. The focus is on preventing hospitalizations, improving quality of life, helping people remain safely in their home. And we know this is increasingly important for many individuals, and especially individuals with IDD as they age. And next slide. Yep. So, like I said, we provide primary care for older adults with serious illness through our geriatric care program before hospice is needed. They need to be homebound adults and over the age of 55 with 3 chronic conditions or with 1 chronic condition and a diagnosis of dementia in order to qualify. Next slide. Thank you. So thank you for being here and for the work you all do. I think, oh, sorry, Rachel.
No, I was going to say, I do see quite a few questions in chat.